and welcome to this press briefing with two officials of the Ministry of Health. This briefing is for both the press and the public. The press will communicate with us via Zoom, and you, the members of the public, you can speak with me by messaging me directly via WhatsApp at 256-1023. The two officials of the Ministry of Health with us today are the Deputy Chief Medical Officer, Dr. Anton Best, and Infection Control Specialist, Dr. Forde. And we're going to be looking specifically at three areas: the end to routine quarantine in Barbados, preventing COVID-19 deaths among the elderly, and thirdly, new visitation rules at the Harrison Point facility. I'm seeking the cooperation of both the public and the press in restricting questions or comments to these three areas today. So let's come first of all to Dr. Anton Best, because as you are aware, the Ministry of Health has put out some new rules for quarantine, in which they're saying that there's no longer routine quarantine in Barbados. So perhaps we should begin by having you basically recap the key points in that press statement which was issued yesterday. Dr. Best.
Good morning, Mr. Ellis. Good morning, everyone watching this press conference. Let me thank you for the opportunity for being here to give an update on what the Ministry of Health and Wellness is doing with regards to our national response to COVID-19, and specifically talking about the new quarantine approach, as I call it. So during the planning phases for the Omicron surge back in December, we decided that based on the expected number of cases and based on the fact that Omicron was less virulent, that we did not need to employ routine quarantine. It was going to be considered to be disruptive. The numbers were just going to be too large for the Ministry of Health, public health officials to manage routine quarantine. So we took the science into consideration, once again repeating that the strain is more infectious, but it is less virulent or less dangerous. So we do not recommend routine quarantine, but this process needs to be managed by public health officials. So the other thing that we did is that we reduced the period of quarantine from 5 days, if there's testing involved, to 3 days. So if a person is exposed to COVID potentially, we can test them at the time that it is brought to our attention with a rapid test. And after 3 days, we can do a PCR test to make a definitive determination that they did not, in fact, acquire COVID. So that's the other change that was made in terms of the length of time of quarantine once testing is involved. So there's some circumstances in which we would still employ quarantine. And those circumstances would be if you have a caregiver of, say, a child or toddler who is the positive case, the caregiver cannot possibly physical distance safely from that child, so therefore they need to remain in quarantine. Or if it's a caregiver of a dependent, such as an elderly parent. In those circumstances, we would quarantine. Mr. Ellis?
Yes, sorry, my apologies. I thought we had lost contact. Now, a major question which I expect many of the people, even the press, will have is this change. We've heard so much talk over the period that we've been fighting COVID. We talk about the whole idea of staying with the science. Yeah. So explain for us to what extent this is consistent with the science.
So absolutely, this is consistent with the science. As I mentioned, before Omicron started in Barbados, we knew that it was more infectious, meaning that one person with Omicron was likely to pass it on to more people. So we expected, and we did this through modeling, we expected that the numbers were going to be larger, but then we also knew that this was going to be less virulent or less dangerous. And that is why we said this is something that we can do and we can do it safely. Now, please appreciate that there are many other measures that we employ from a public health perspective, such as case detection and isolation, to be able to mitigate the impact of a COVID surge. And we employed all of those other strategies, but we dialed back the need for routine quarantine in Barbados.
Okay. So we're going to take some questions directed to this whole question of routine quarantine. After we hear from Dr. Corey Forde, the infection control specialist, as he talks about the approach to dealing with the elderly and the new plans that they have with respect to visitation rights at Harrison Point. Good morning, Dr. Forde.
Pleasant good morning to all Barbadians, and it's indeed a pleasure, David, to be back. I've been on the media for a while. We're busy, certainly, managing a series of patients at our facilities across the country. I just want to start off by saying, David, before I get into any details about what's actually going on in facilities, I'm thankful for God for strength, for myself and all the team members. And I take the opportunity, I have not done it before, to really extend my greatest thanks to our team at Harson's Point, but specifically to the young doctors who have toiled for almost 2+ years, Dr. Corbin, Dr. Gibson, Reese, Gamble, Holder, Lewis, Lashley, Paris, Riley, and Jackman. And I really had to do that because I think they have really put in a tremendous effort to see certainly the country where we are today. These are young healthcare professionals. And with that, I really want to go in to give you a bit of flavor as to what's really going on within the country in terms of our isolation facility centers. As of this morning, and this number changes minute to minute, but we had 126 individuals over 7 o'clock this morning who were PCR positive across our 3 current facilities. We had 8 negative individuals within the facilities who are actually dependents. We'd have had 24 persons admitted overnight, and as you know, certainly from before, we're basically admitting individuals who are extremely ill to our facilities, and thankfully we would have had at least 11 discharges or so overnight. There were 2 recorded deaths yesterday, 1 within our facility and 1 within the emergency department facility. And we currently have across the facilities in our primary and secondary isolation 3 individuals between the ages of 17 to 40 years of age. Now, I have always said, certainly to the country when I speak, that I will speak when I think it's necessary to speak. And this is one of those occasions which I believe is strategically important. And I need you really, as you listen across the airwaves or television today, to listen carefully. Now, in our primary isolation area, we have 11 patients, so that's not so bad. But we have 3 of them currently are ventilated, whether it be what we call non-invasive ventilation. We don't put the mask on the face, or tubed, only 1 individual. And that team of Dr. Lovell, the doctors who are the doctors from QEH, internal medicine department, and Dr. Edger, were able to get another individual off the ventilator, and we applaud them for that difficult feat, which is seen all over the globe. We have, as I said before, another 31 persons in the ICU between primary isolation, A, B, and secondary, 31 individuals on oxygen therapy. So that's still quite significant. But I really want to get to a significant point. When you look at secondary isolation, which is really our high dependency unit area, and this is something I've been really monitoring, and as you know me, it's really dear to my heart. When it comes to elderly individuals, I've always said that I grew up with my grandparents. It's my story of my life, and they taught me much of what I know, and it certainly got me to the place where I am today. But in that area, we have a total of 15 very ill elderly individuals, really above the age of 80, and it's really heartbreaking. They're very ill. The prognosis, is not that good, and they have multiple comorbidities. The truth is that we're fighting our best with them. There were more than that, and we were able to get a few home. Recently, an 86-year-old, I know we got out yesterday. His prognosis wasn't good, but he turned the corner, and I thank thank the team for that, and thank God that we're able to get him out. But why am I on this? I think it's important because since the Omicron saga, as I would call it, there were a total of about 39 deaths, and the median age was 72. Why is this important? I think we as a country, certainly, we recognize the importance of our elderly population. They've really gotten us to where we are today in many things that they've done in the past. And I think we need to pay special attention to this particular group at this time. I think for most of you across the country, you need to check in on your elderly individuals. But I think more importantly, apart from checking in on them, I think where you have your elderly granny in the home, or your mother, or other elderly people, maybe your elderly aunt, etc., in the home population, we know in this country at present that there been a relaxation in some of the protocols across the country. But as we do that, I think we as country people need not to only think about ourselves and the ability for us to go out and do things that we have not done, certainly within the last year, or for some instances, the last 2 years. But we need to recognize that they're elderly people and they have multiple comorbidities, and the risk to them can be high. And so I really want to pay special attention to that. But to take it a bit further, apart from being our brother's keeper or our family keeper, we also need to do a few things. So apart from checking in on them, we need to check their vaccination status. If you have them out there, they're not vaccinated, I'm begging you, please, try to get them vaccinated. And the important part, getting them boosted so that they're fine. We know after about 6 months, some studies will say even shorter, that there's a waning off in terms of the vaccination. So this brings the importance of the boosters in that particular population. I would say that for those individuals who've died within that population in recent times, the challenge for us is that many of them had multiple comorbidities. And that's always a challenge in any country across the globe. We will continue to fight to save every single life and with every strength that we have in our bodies to make sure that we can get these individuals safe and back home to their family. But we need you, certainly, as a public, to fight with us with that process. And my last point is, we as a country never certainly got to the numbers that might have been expected. And why was that so? In the context of what I've just spoken about. Good governance, protocols which were in place, but I think sometimes we don't give the public the credit that I think they're due. And I just want to tell the Barbadian public today that I believe as well that a lot of the outcome which we've seen, certainly with the Omicron outbreak, which did not look certainly in most cases like the rest of the world, it was because of you and the sort of efforts that you've put in. Barbadians are knowledgeable people. If you give them the information, I expect they will act on it. And I'm asking you to act on this information that I've given you today. So congratulate you for your efforts, certainly in the fight in the pandemic. And I really want to encourage you to continue to follow the protocols which are set in place so that we continue on a smooth journey as we go through this storm. Thank you.
Thank you. And could you go on from here to look at the new visitation rules at Harrison Point?
Thank you. And I brought to the table, and I probably should say, David, before I go on in terms of case fatality, our case fatality is about 0.73%. We look at the global average, you're looking at something like 2.2% or greater. So we are, one death is one death too much, but certainly we're not even near in the realms of what's going on in the rest of the world in terms of that. And I think, again, that's something that needs to be looked at. But in view of what we've seen, and really relooking at stuff, and I believe that we've done well in this country consistently because we've looked at we saw what was going on globally, but we also saw what's going on locally, and we know our people. And I think when you look back and you look at the different variants, you have to kind of restructure, rethink, refocus. And one of the things certainly we met as a team and discussed significantly was and proposing was some sort of visitation for people is difficult. When your relative is in isolation, and yes, you may have a video call, yes, you may hear them on the phone, but it is difficult. So what we've come up with, certainly as a team, and it's going to be a very structured process, just let you know that, it's very, 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 very structured, is we will allow, if you have a positive person, obviously in the facility, who is in primary isolation A, and we'll start off like that, and then we'll see how we can progress. I think it's good to start and then expand, as opposed to go too fast and then you get yourself in trouble. So we'll start in primary isolation, where we have our most sick persons in the facility, in primary isolation A. And what we're going to do is allow, if you are a positive individual at this time and you have a family member in there who's gravely ill, we're going to allow you to visit, but in a very structured fashion. You would imagine that, sometimes we spend like 8 hours, David, 6 hours, 7 hours, sometimes for some people even longer in. And I think the point I'm making with that is that obviously we have to have a lot of people we have to take care of, so we have to make it very structured. To try to bring you in, we will bring you to the facility, and we will take you back, because you're still in isolation. So we don't want you running about, catching a bus, for example, or driving your car to Harson's Point, etc. So we will bring you in a structured way. And this will be communicated through our client relations department, which is a very active department within the facility. They will communicate with you and structure a time in the afternoon. And we'll take at least 4 visits for 4 different individuals to the facility. It's going to be very structured. You bring you in, you get the opportunity to talk to doctors, you get an opportunity to speak to your relative. And if you have any questions, I'm sure the doctors on the ground will do that. But it's going to be in the afternoon, obviously, because we have 100 and something patients, David, and our aim is to make sure we take care of them. And take care of them and make sure that they're safe. So when we've done that, we will take the opportunity to speak to those relatives. And we're going to start off by doing that hopefully early next week, Monday. And bring people in, let them talk to the families, get to talk to the doctors, to try to bring back. And I told the team there must be an element of humanity in this difficult situation that's being faced globally. Many countries across the globe have not done this, but we're going to attempt to do it in a structured fashion, and we hope that Barbadians will work with us as we work through the process. Thank you.
In this case, you are restricting it to people who are already positive.
Yes, yes,
So
yes. We're not bringing negative people in the facility. It's too risky. It's what we call at Harson's Point the hot zone. So I think it'll be very risky. And I think I've always said before, there are 2 things that I always live by. I wouldn't want to do something for myself that I wouldn't want, someone else to experience. So I think we're trying to do it safely, and we'll look at how it goes. And maybe that might change, David. But I think we start here, and then we see how it goes. I think the element of humanity and this particular Omicron outbreak has to change. If I'd looked, and I would probably never try this one in Delta, because Delta was very tricky, and people could get very sick, and you really don't want to take that risk. For Omicron, the person is positive. I know now from international data, risk of reinfection and this causing trouble is much less. But for some of the other variants, it would have been challenging. So I think it is time that we certainly move to this particular event, and why I really push you to know I really push this, and for concern for the average Barbadian. Thank you.
But what more can you do for the person who has a relative at Harrison Point but is not positive? That person is negative and has the same desire. How much more can be done for them?
I think we have, and I've always said, and I'll say it again today, a very straightforward fellow. I think when this first started, it was a rocky road, David. It really was a rocky road with the number of people we had, with the level of communication that people wanted in that context. It was difficult. I think what we certainly introduced at Harson's Point, as you know, is this client relations service. We even have now calls that they call people and check in on families and make sure they're okay. So we started a client relations service and a psychological service, and we just introduced psychological aids, and that further helps to communicate with relatives, and it allows for some of these aids, whether it be psychological aids or the client aids, they actually interface directly with the patient and the relative. So whether it be by Zoom or other pictorial methods, there's scope. And there is scope, and we have used it. I've used it myself, certainly within isolation, to allow for not only Zooming, but for telephone calls, even from my own personal phone. I have done that as well to facilitate communication between those who may be elderly and may not have cell phones, or people who simply didn't have any credit. I think these are all the human side of things that I really encourage at the facility in these really difficult times. Thanks, David.
Thank you. And coming back to the question of deaths, one feature of what we've been seeing in recent weeks has been reports of the number of fully vaccinated people who have come down with Omicron and who have died. And as you've said, many of these people are in the older age group. But what figures are you in a position to advance in terms of what has been happening in this regard?
Yeah.
The fully vaccinated versus the vaccinated.
Thanks, David. Interesting question. But if you look across the whole pandemic, I mean, our median death rate was about 70 years of age. Somewhere we started with as low as 12 all the way up to 104 years of age. And if we look at the Omicron, I said there were 39 deaths, but I think everybody who's listening to me today will well know the large amount of people in this population who've been certainly being positive. And if you do a fraction of that on that, you'll see that, that is extremely low. The median age of that was 72 years of age. And of that population, there have been, of 39, there have been 8 fully vaccinated individuals and 1 partially vaccinated. But what I would say with regards to that, and I think this is very important, and I did mention it, and I'm going to hound on it again, and it is that, yes, it's okay to have your 2 shots, but it's also strategically important that people be appropriately boosted. So I think a lot of Barbadians would have brought granny out, or a great aunt out, or my own granny out, to get vaccinated, or maybe an adopted granny out to get vaccinated. And they get vaccinated, they get the 2 shots, David, but somehow they've not made it back for their booster. But we know certainly that after starting about 3 months, that is a waning. So one of the key things is to get those persons vaccinated. But I'm going to tell you the other key point. The other key point is, despite being vaccinated, yes, we acknowledge you can get Omicron. But I think the point here, which I think is strategically important, is if you have your elderly grandma, your great aunt, whoever at home, is if they're ill, bring them early. This is one of the challenges we saw among this population of deaths. So bring them in early. You might not want to bring them to Harson's Point, so we created an avenue for you. So these assessment centers where you're not sure if granny may have diarrhea or she may have vomiting, you bring them in for assessment. Don't wait till they're late. And I would tell you, I know my granny. Straightforward. If I told my granny, listen, you need to go to the doctor because you get this sorted out, she probably will tell me, I ain't ready to go to no doctor, I'm going to be fine, I'm going to drink this, I'm going to drink that. But I'm telling you to encourage them to get assessed so that they don't end up in a situation where they present, for example, to the emergency department too sick and too far gone. It makes it really, really difficult for us. So encourage them to come out to these assessment sites. If there's anyone is unsure, get them assessed. We'll do what we need to do. If they need IV fluids, we'll give it to them. If they need antibiotics because they have an intercurrent infection, we will do that for them. If they have problems with their diabetes on top of COVID, that is a challenge, we will fix that. And even if blood pressure is low, we will think that if they need a hug and a level of caring, we will do that as well. And we have done it throughout the whole pandemic. So I just really want to say that those 2 key points, get granny boosted, get auntie boosted, get uncle boosted. And if you ain't sure and they have COVID, get them evaluated. This is what these isolation facilities outside of Harson's Point are about, identifying people that can get in trouble and preventing them from getting to that point. Like I said before, and it's dear to my heart, that many of these individuals have done a tremendous amount of work for this country, whether it be domestic work, cutting in the cane ground, working in some of the more strategic areas in this country, whether it be tourism, and so we need to defend them. And we are all, as residents of this country, need to protect our elderly. Thank you.
So Dr. Forde, as COVID advisor, one of the things that I've noticed is that there is a creeping sentiment among some. I can't say whether it's a majority. I doubt very much it is a majority. But I think a significant enough minority of people that I hear with the narrative that says, look, the fittest will have to survive. The elderly, if a person is 89 and 90 years of age, they could as well go long. We really should not be held back by these people. You put this within the context of the contribution that they have made in the past, but there's no focus really on what contribution they actually make to the lives of the people that they are with. And there is an underlying assumption that when a person hits 89 or 90, that person is a burden to whoever they're living with. And I get the sense that the country needs to engage in a discussion on this aspect of it. What is that contribution, both economic, social, and cultural? And when I talk about cultural, we talk here about the oral history of Barbados and things like that. The country, from where I sit, really needs to stop and think about that. But then there's a deeper issue here. It is about human rights. We have to be careful that we are not launching into a period now where human rights are seen as the rights of those who are 40 years and under alone, and that it is seen right across the board. So I put that to you. I don't know to what extent you might have heard it as well, but that's what I'm picking up as well.
I'm not a social media junkie, but I've heard it before. But what I would say is, and I always use my own personal experience sometimes to bring across points. I think for most of you, and I look directly in the camera for this one, because for most of you who are out there, certainly you've done well. I've said before that one of our key things that I believe in this country is the capacity or ability for us to have become educated and to be able to represent ourselves. I would chance to say that almost 80% of the population, whether 40 or above is the number you gave just now, that percentage of individuals had a major influence from your grannies. I'm telling you, or your grandfathers. They had a lot of input into your own personal development. And I think that that's important. But I also think from going around and talking that I think we cannot lose this population of individuals to this, and I'll tell you why. I spend a lot of time, apart from doctoring, walking around the facilities and talking to many of these elderly people, some who are very ill. And one of the things that I often grasp from them is I learn little clues, little things from them. And I think that we need, as a country, to look at what they can offer, even at their age. And so I will chance to say again that for all of you out there who have the elderly in your household, there have been an important part of the development, I believe, of this country, and as of individuals, and of people's character, and of people's capacity to be educated, and of people's capacity to catch the bus, and to do the simple things in life. Even I'll go as far as, I don't get political, but as far as possible, to even in terms of NIS, etc. So they have built that capacity, I believe, in country, for which we have to be grateful. And I think part of that gratefulness involves saving as many of them as we possibly can. And you have the opportunity to do that. I know you want to get back out. I know you want to have fun. Me too, right? I know you want to fly out, but still be conscious of that person in the household. And going back to say, to me, the most important point is, if they're positive, if you think they're ill, if you ain't sure, I'm begging you, please bring them in to one of the assessment facilities. Let us look at them. We've done that recently. We picked up a few people that were able to pull back. A nice old lady, I can't call her name on this call. I really grew to love her. When I leave her, I'm going to discharge. I told her, you got to hold her until I go back and discharge her, because I have to talk to her. And she was dear to my heart. I think we have to look at that and not forget, the things that you've mentioned, David, and the things that I've mentioned. They're all a part of who we are as Barbadians.
In addressing this issue, what advice would you give to members of the public in dealing with the elderly after they have left the kind of care that is given to them at Harrison Point?
I think that's a really good question, because we spoke before about long COVID, and I guess that's where you're going, David. And it can happen to the elderly as well, you know, and so they continue the normal medical care that they normally have, whether it be at the polyclinics, which are available. Their general practitioners have those follow-ups. They often send notes. When things were tough, it was a bit difficult with the sheer number of thousands of people we would have had in isolation. But we send the appropriate notes to the doctors for follow-up, to watch them carefully. They may have joint pain. Some may even develop diabetes. Some may develop thyroid disease, for example. There's a little gland up here that can cause some trouble sometimes post-COVID. One of the common things we see is a lot of joint pain, and they have arthritis. So you might just think it's putting out the arthritis. But if you're not sure, go back to what I keep saying all the time. If you're not sure, get them that level of medical assessment to make them as comfortable as possible. The eating will not change. Many of the other parameters will not change. If they still have difficulty breathing, even post-COVID, which can happen for those who've had respiratory disease, of course, we get that appropriately assessed as well. And the healthcare system continues to function to allow for that to happen. So I don't think you need to say, okay, well, I don't want to take them here, I don't want to take them there. Get them assessed. Thanks.
Let's take some questions from the public and from the press, reminding you that we are restricting those questions to the three subjects that we have on the agenda today: the end of routine quarantine, preventing COVID-19 deaths among the elderly, and the new visitation rules at the Harrison Point facility. Good morning let's go to the press first of all. Good morning.
Hi, good morning. Yes, Colville Munzi from Nation News. Now, on the question of the end of routine quarantine, there are some who might say that this is counterproductive to the idea of curtailing spread. Now, should the potential person exposed, and this is a question I guess directed to Dr. Best, turn out to be positive, what measures, what safety net is being put in place to ensure that that person doesn't potentially expose others in that 3 days or so that they are waiting the follow-up test?
Thanks a lot for the question. So in the prevention and control of COVID, we have a suite of public health and social measures that we recommend. So I would have talked about the case detection. Of course, there's isolation, whether it's facility-based isolation or isolation at home. But then there are other measures that we talk about all the time, the non-pharmaceutical interventions such as hand sanitizing, physical distancing, ensuring that there's good ventilation, etc. In addition to that, we also recommend that persons, if they are ill, should stay away from others and especially stay away from work. So the comment that you made was that the removal of routine quarantine was going to be counterproductive, and we argue against that on the basis that it is no one strategy that is going to work to mitigate against the spread of COVID in any place in Barbados. So it is a whole suite of strategies. We realized that based on the sheer numbers, we simply could not continue to do routine quarantine like we were doing, say, a year ago. So we were very much justified in ending routine quarantine. Please appreciate that we are approaching the 2-month mark of this particular surge, and you will see that the numbers are coming down. So if the removal of routine quarantine was counterproductive, we would not have been able to contain the spread of COVID, and we have contained the spread of COVID. But we still need people to continue practicing the public health and social measures, the non-pharmaceutical interventions, to be able to continue to mitigate and stamp out this particular surge that we're experiencing. It depends a lot on personal responsibility.
Mr. Munzi?
Yes, a follow-up question as well. Now, the notion that the Omicron variant is less virulent. Mm-hmm. Now, in recent days we are seeing deaths at a rate in some cases 2 per day. Now, I know when we compare our death rate to the world average, it is still pretty low, but the realization of 39 deaths in 2 months from an Omicron surge still must give some pause. And again, I must ask, how does this stack up again to that reality or that notion that the Omicron variant is less virulent, given the number of deaths that we are seeing? And if you could confine your answer to the last 2 months for comparison purposes.
So if I may repeat what Dr. Forde said, is that we have a more contagious strain, of COVID, which is Omicron, so the numbers are considerably larger. But it's also less virulent, and we knew this before Omicron hit our shores based on the experiences in the UK and in South Africa. So part of the reason we're having this press conference is to discuss the deaths that we are seeing. Dr. Forde did also say, and this is something that we've said repeatedly, we do not like any death. So one death is one death too many. But the reality is that some people will die from COVID. We want to mitigate against that. So Dr. Forde would also have mentioned that first of all, it's elderly people who are dying. It is probably people who are unvaccinated. It is persons with comorbidities. The other thing that we have noticed is that people are coming in for care late, and that is problematic. So the earlier you come in for care once you've been diagnosed with COVID, or if you have symptoms in keeping with COVID, that increases the likelihood of survival, increases the likelihood of success for the interventions that are required. The other thing that Dr. Forde mentioned, which I need to reiterate, is the fact that vaccines make a significant difference. So we're encouraging people to get vaccinated if you haven't been vaccinated. And if you have been fully vaccinated and more than 6 months has passed, we really recommend you to come forward and get boosted. So this is a message to all persons in Barbados. This is a message that we want the persons listening who are not yet boosted to come forward and get boosted. We also want persons to encourage their peers, encourage their parents, encourage their grandparents, encourage persons in the community to get vaccinated and to get boosted to reduce the likelihood of an adverse outcome such as death due to COVID-19.
Before there's a question here referring to your mention of assessment centers, and they want to know, where are these assessment centers? That's what this questioner wants to know.
And thanks, Dr. Best, for taking that question. It was a good rehash of what I've said. That was like a summary. Thanks for that. Right, so these assessment centers, and they're not walk-in assessment centers, so you have to call through the operations center or through the home isolation team, or the general operations center which basically coordinates all of these centers and everything across the country, and then they will instruct you to come in to be seen. So these centers are, one is at the center in Belleville, the 4H Hospital in Belleville, and then in Mangrove, St. Philip, which has a much larger capacity. And the original plan was to try to service, certainly in Mangrove, people within that area. We've had people within that area itself actually come in and be assessed, and we kept it. A few of them were able to treat and discharge or advise and send back to their families. But that's in Mangrove. St. Philip is at the Barbados Workers Union Labor College, Barbados Labor College. We have a full hospital system set up there. So give you a good idea. So we have a 12 assessment bed unit. We have a 6-bedded high dependency unit set up just in case someone turns up very ill, as they did last night. One individual was transported to Harson's Point this morning. And we have another 32, close to 40 beds available for individuals where we can give IV fluids and treat nausea, diarrhea, and severe vomiting, which in this particular part of the pandemic we've seen associated with some what we call renal disease. So for simple Barbadians, your kidneys not working too well as a result of all the loss of volume in the body. So we try to pull that back early. If we do this early, Marty. If we do this early, what we avoid is some of the long-term issues that we can be faced with, the kidney problems, etc. So this is important. David, thanks.
Let's take another question from the press. Good morning.
Hi, good morning. Marlon Madden, Barbados Today. I want to start with getting some clarification on the issue of the visitation. I'm trying to figure out, are we talking about people who are positive who want to visit a loved one in the facility, or is it open to anyone? And could you shed some light on how this visitation will be done? Let's say I go there, and will I be put, will we be talking through a wall, through a glass? What will happen?
Marlon, thanks for the question. I'm just going to repeat it a bit. I think I mentioned it earlier, but I'm going to clarify it for you, just in case you didn't understand. So we said before it's going to be structured. So I believe, and team knows, structure is important. If you don't have structure, people will perish, right? So structure is very, very important. And we've said before, we're going to have at least 4 visits of 4 individuals per day, and we're going to have 1 slot left for emergencies. For example, if people are already on a visitation schedule, but somebody deteriorates and we really want to get that family member in, then we will go by that mechanism, adding that person into that particular slot. The plan is at present, it's very simple, nothing complicated. If you are positive and you have a positive family member in the primary isolation A, notice I said primary isolation A, this is where we have our illest individuals at present, and this is how we will start and probably expand. And as we expand, we'll let you know. Those individuals, families will be contacted, so we're not bringing 5 and 6 individuals at a time, but certainly 1 or 2 individuals who can be identified by the family to come in, and we will collect you. We will bring you to the facility in an organized fashion. Our client relations team will advise and give a debrief. Our infection control team will also debrief the individuals before they're actually taken into the area. Although they're already positive and there's no risk for them to be positive again in the short term, we are still going to be super cautious because we're dealing with ICU patients. So yes, we will allow them to wear a minimum amount of protective equipment, and it's not really to protect them, but to protect them from giving any other bugs to the people inside. And this is not unfamiliar with ICUs across any part of the world where you may have an outbreak or of any other infectious illness. So we'll walk them through the process. We'll explain to them what and what they cannot do. And this is all very important before they go in, and we will set up. Certainly the doctors, we had discussions about this, lots of discussions. This is one of the things that was very important for me to try to implement. We had a major discussion with the physicians about, having that time and talking to persons while they're there. Sometimes it's not always possible. Sometimes there are emergencies, but we will do our best to ensure that it happens. And I hope that Barbadians, and I say this from now, would understand if there's an emergency with another patient, that visit might be cut short, and they'd be understanding to that particular aspect. And it will only be, I think we discussed with the physicians, it's probably best only in the afternoons because of the sheer amount of work that is done. I think when people come, they might very well appreciate. Now, one patient alone can take about 2 hours, sometimes an hour, to actually see in the ICU because it's very, very complicated. And I think they might have a better appreciation of that, apart from getting the opportunity to see their families. And then after that, we go back to the debriefing area, which we'll set up. We will talk to them if there are any other questions or queries that they may have at that point. We may try to answer. If we're not able to do that, then the appropriate contact will be done by client relations through the doctors to allow that to happen. And then we will take them back to their residence to go back into the appropriate isolation. So I hope I walked you through a bit from top to bottom. But because that happens, it does not mean that I think one of the things I really think on is as best as possible, allowing for people to still communicate with their families. So even though that may happen, Marlon, I will still push for the psychological services to maintain the psychological aid, which is a new aspect to Harson's point, to be maintained, and the client relations aspect to be maintained. I want to shout out our client relations team Dr. Ray Carbon and Mr. Nicholas Eiffel, who've worked, I think, very hard in this aspect and trying to improve it across the facility. And I think here within is another opportunity to continue to improve that relationship between the average Barbadian and the ill relative who's inside, whether they're able to speak or whether they're in a ventilator and they're not able to do that. So people appreciate how ill their relatives are. I know it's been difficult over the last 2 years. The norm of going in to visit people has not been there, but we will try to change that in this particular aspect. How successful we are always also depends on you and how you cooperate with us as we go through a difficult process. Like I said, when you're starting something new, I always tell the team this, when you're starting something new, sometimes there are hiccups, sometimes there are difficulties, sometimes there are challenges. But the only way you're going to get past the difficulties and challenges is to actually try. Identify what the issues might be or the challenges might be. And if we can identify that, we can fix it, we can perfect it, then we can expand the capacity to do that, and maybe even look in the future to doing it on even a more expanded basis. Thanks, Marlon.
Marlon Madden has a follow-up question.
Yes, this is in relation to something else that you mentioned, Dr. Forde. You're urging Barbadians to check in on the elderly and taking care of them. And notwithstanding that we've been doing a very good job at the facility, at the Harrison's Point facility, there have been some complaints about ill treatment of patients. The patients are not satisfied with how they're being treated. Some of them are unable to shower properly or move about easily. What's the level of frustration like among staff at this point?
Okay, Marlon, answer. You started with a premise, right? But I always say this. I always say this to every Barbadian. I say this: where there's a problem or a problem arises in the facilities, I always tell the team, do not get defensive. Our responsibility is to fix issues and to improve things, and we've done that. I think we've not heard the large amount of complaints about many different issues within the facility, Marlon. I don't know if you're still hearing them, but certainly I'm not. As we've had in the past, we've had challenges, yes, but I think the strength in a program or the strength in a facility or the strength in management is identifying what those problems are, Marlon, and fixing them and finding amicable solutions for a difficult situation. There is no country, Marlon, none, in the globe who managed COVID with perfection. None. Those who had money, those who didn't. Those who had 20 patients, those who had 20,000 patients, 30,000, 1.7 million patients. And they all struggled. So we recognize that these were difficult times. So way back when, and I'll take you back in time, Marlon, take you back in time to Delta, when we had hundreds of people in isolations, and at some point, thousands of people in isolation, there were challenges. And I think at every corner and at every point that the staff tried to do their best. And we implemented different things. I said today, we implemented psychological aids, which is a new phenomenon. We had a psychologist which we brought in, which we thought people were having challenges, obviously in isolation, not only in facilities, They had problems at home. We brought in the psychological aids to work along with our now 2 psychologists who are on site to try to identify these issues early. And they flagged them back to administration. But we didn't only do that, Marlon. What we did was to start a client relations department. That didn't exist. But we recognized that there was a need for that. And I think that speaks to leadership. So you started a client relations department, but then there were only 2. So we said, no, that can't happen with thousands of people and hundreds of people. What we did then was to start expanding that into a client aid. So we trained many of the young people you see across this country who are fighting in this battle in that client relation aspect of communicating with relatives, to improving that communication strategy across the facility. So many of those complaints you would have heard in the beginning kind of disappeared. And then we took it further. So that client relations group, I mentioned the names of the individuals, actually took it a bit further. So what they actually did now was to improve in terms of calls, in terms of using FaceTime, using technology to communicate with people. And for the elderly who may be in the facility, and I'm glad you brought it up again, we make a special effort to reach out to families. And I will tell Barbadians, I tell the team all the time, reaching expectations sometimes, we will never reach expectations in meeting everybody's requirements because of the sheer difficulty in what we do. and the time space. And I always tell them, I know you asked the last part of the question, is not to get frustrated, but to use every difficulty, to use every challenge to build strength. And that's one of the things that I learned. And sometimes it can be a bit tough in trying to say, look, this cannot happen, we have to fix this. But I think they understand the underlying goal is to improve and continue to excel in what they do, and to continue to provide the best level of care that we can, recognizing that everything will never be perfect. But we have to aim for perfection. If you don't aim for the stars, then you're going to be in the ground. I'll finish off by saying this. I spoke a bit here because I think it's important. And I always tell the team, I'll share one of the things I always tell them all the time with you today. And the average Barbadian can even use this in their own life. I said, in life, we can be eagles, or in life, marlin, we can be turkeys and sit on the ground and goggle, goggle, goggle and complain. Or we can sometimes be chickens that scratch on the ground and don't want to fly and soar above. But when we have challenges, we have to soar above those challenges. We can't sit and complain. We can't sit and hope that they get better on their own. But we have to put our best foot forward and soar above those challenges. And with that, we also have the psychological services on the ground, which can talk to our staff if they're having any challenges. Thanks, Marlon.
Thank you, Dr. Best. We have a question here from more than one person relating to contact information. And I believe that stretches into the taking of temperature. Since there's an end to routine quarantine, these people are asking questions about the continuation of the practice by businesses and at funerals and places like that, where they have to leave their contact information, their telephone number, and all of that, and be tested for temperature as they enter the building. What's the position on that?
So David, when we talk about ending routine quarantine, I would have explained the circumstances under which we're going to end routine quarantine. The question that was posed is peripheral to the discussion on routine quarantine, and in fact is being addressed in the directives that come out. And I believe that the next set of directives are due in just over a week, about a week and a half actually. So those specific requirements of organizations, of businesses, will be addressed in those directives. This is not touching those specific interventions that are articulated in the directives.
This question, I believe, was touched on earlier, but it may be worth repeating.
Sure.
If an employee tests positive, are they to come to work since quarantine is not necessary? And during the 3-day period between the rapid and PCR test, is the employee supposed to be at work, seeing that the virus can be transmitted during that period?
Okay. So, David, that's an excellent question, and perhaps in my opening presentation, I should have made those areas clear. I also should have explained the difference between quarantine and isolation, because based on some comments that I'm getting, people are actually conflating the two. So essentially, quarantine and isolation seek to do the same thing. It seeks to keep people away from others. When we talk about quarantine in the strictest sense, we are talking about a person who is potentially exposed to COVID and using it as a public health tool or measure to reduce the likelihood of spread if in fact that person was infected with it and we just don't know at this particular point in time. Isolation, however, is when we know of someone who is diagnosed with COVID-19 for sure. So the initial part of that question really is about isolation. If you are diagnosed positive, you are isolating. You are expected to isolate. You cannot be expected under normal circumstances to go to work. So let us look at the scenario in which you have someone who has been potentially exposed there, so their primary contact. What happens in terms of them returning to work? If that person needs to return to work, and that is going to be the case in many circumstances, you need to do a rapid test. The rapid test, when you find out about that person, is going to tell you if that person has COVID and if that person is infectious. So just because that person is a primary contact, it doesn't mean that they definitely did not have COVID. In terms of the index case being found first. So yes, you would have made the diagnosis in somebody else, but it doesn't mean that the person that is coming to you could not have been the index case in the first place. So that is why it's important to have a starting point. We've shortened the quarantine period. So the quarantine period is after 3 days. You will do that PCR test to determine if, in fact, that person was exposed to COVID and has converted. So at the end of that period, the PCR test would definitively tell you whether or not that person has COVID. What happens in the intervening 3 to 4 days is that that person who is returning to work has to adhere to all of the measures that we have been talking about for the last 2 years. So they have to wear a mask. They have to sanitize their hands, whether with alcohol-based hand sanitizer or hand washing. Ventilation is also a key non-pharmaceutical strategy, and physical distancing. So all of the protocols that organizations and businesses have in place have to be adhered to as strictly as possible to reduce the chance. The other thing that we would tell the person who has returned to work is, hey, if during this time you start to develop symptoms in keeping with COVID-19, please alert the public health official or please go to your nearest testing site to be tested, or alert the person who is managing you. Another key point, and I did state this earlier, but I'm going to state it again, this process has to be managed by public health officials. So the public health officials that I'm referring to are the polyclinics across the island. They have to guide this process. Persons also have access to the Ministry of Health headquarters through the COVID hotline. They also have access to the other public health officials who are based centrally at the Ministry of Health to get guidance on this particular issue.
This person writes that, bearing in mind what Dr. Forde and Dr. Anton Best said with the need for boosters, why hasn't the data on the booster status of those dying been issued? People out there are saying, if these people who died are fully vaccinated, what is the point of getting vaccinated?
I'll take that question first before I hand over to my colleague, Dr. Forde. So the question is asking, why have we not presented data on persons who've been boosted? I am sure that data exists. It needs to be analyzed. However, going back to what Dr. Forde presented when he talked about the total number of deaths, we see that the lion's share of the persons who have died from COVID have in fact been unvaccinated. Okay, so yes, people can still die with COVID, and we would have talked about not only today the reasons why people die. The vaccine certainly is not foolproof. It only reduces the likelihood of death. It does not totally eliminate the possibility of death. So I take the point that this is data that we need to analyze in terms of persons who are boosted and in terms of what is happening there, but the scientific evidence otherwise or outside of Barbados is telling us that boosting works. Once again, boosting occurs in a person who is fully vaccinated and has gone 6 months beyond the being fully vaccinated, or the second dose in most cases. That is when the immunity wanes sufficiently and boosting makes a significant difference. So the Ministry of Health and Wellness is highly recommended that persons be boosted to once again reduce the likelihood of severe disease and to reduce the likelihood of death.
Another question from the press.
Yes, hi, good morning again. Given that and this is a question for Dr. Forde, the epidemiological manifestations of both the Delta variant and the Omicron variant differ, the persons that are getting sick right now, are they still presenting with upper respiratory issues, or are we having a case of, how many, because I know originally with the advent of Omicron, there were concerns of kidney issues and so on. What exactly is the majority of persons that are getting really ill coming down with at this point?
Thanks, Monty, for that question. I think I answered it before when I started, but again, I'll go back. Right. So as I said when I first started, that we have about 31 of these individuals on oxygen. I think what you need to remember, Monty, and I said it in the beginning, we have 126 patients, right? We are only taking people who are red, so people who have severe to critical illness. So the majority of people who may have a little bit of diarrhea, a little bit of sore throat, a little bit of vomiting, a little bit of cough, a little bit of what they think might be sinusitis, are actually at home. The people who were admitted to our facility, for most part, some social cases we have admittedly, the most of those individuals are ill. So they come in with severe diarrhea or vomiting with kidney impairment, or they come in with respiratory issues. And we're not different from the rest of the world. The rest of the world has also seen people presenting with Omicron with respiratory disease. So it is nothing abnormal or different to have people present with respiratory disease. Remembering again that the majority are actually not presenting with that, the majority are actually at home. So we will have a percentage of people who, within your own population, will present with respiratory disease, as we may see on occasion. Like I said, we have about 31 persons on oxygen. So apart from presenting with respiratory disease, yes, you'll see people with sore throat. Yes, we'll see people with diarrhea and vomiting. But diarrhea and vomiting still, for the home isolation group, and sore throat, still remains the most common form of presentation. Some people will have nothing at all in terms of their presentation in terms of COVID. But I just want you to always keep in the back of your mind that the most sick people is different to before. So the most sick individuals we are going to be taking in at our facilities. The question you must ask me is, at the assessment centers, what are we seeing more often? And we're seeing at the assessment centers, when people are coming in, we're seeing individuals who have diarrhea. People have a bit of vomiting and they can't keep up, anything. So we're still seeing that. But our main isolation facility, we're seeing that with the endpoint, which is a little bit of kidney impairment. But we're also seeing it with some electrolyte abnormalities, like sodium might be low, etc. I'm going into too much medical detail. And we are also seeing people, again, who are requiring oxygen again. So a certain percentage of your Omicron population will still present with respiratory illness. It's not only in Barbados, it's the rest of the globe that they're seeing. If you look in the US, for example, the ICUs of people were still being intubated, people were still being placed on oxygen. If you look at UK, you see the same thing. If you look at Russia, you probably see the same thing. So there's really no difference. And I think the point is here that care must be taken by every single individual. That if you know you're ill, you're not feeling well, present yourself. If you're not sure, go to the assessment centers, right? But do that in a structured fashion by calling in, letting them know, and we will see you, figure out what's going on, and either fix you at that point, keep you for a couple of days, because the rollover period for those centers is like 72 hours, or manage you how we think you need to be appropriately managed at that site. So Monty is varied.
Sorry, this person may need a little bit of clarity from you, Dr. Best, because they're saying, I'm at a loss for Dr. Best's answer, because if they're not doing contact tracing, what is the relevance of persons taking names, etc.? I'm confused. So could you clarify for them exactly what you're telling them?
So the contact tracing is yet another measure that we have been using from the start of the epidemic here in Barbados, and that's been almost 2 years now. However, in the middle of last year, if I remember correctly, we realized, look, the numbers are just too much for our system to manage. So contact tracing had stopped. Routine contact tracing has stopped a long time ago. Notice I said routine contact tracing. We still have to do contact tracing in select circumstances. So you may use it, for instance, in the security forces, you may use it in healthcare facilities, etc. Once again, it is the public health officials who are making the determination, do I need to do contact tracing in this particular circumstance? The question that was asked was asking about something that is in the directives and has been for a very long time, about temperature checks and about documenting the names, etc. I cannot respond to that because that is in the directives and that will be dealt with accordingly. That is not being dealt with in this press conference.
Let's take one more call from the media before we wrap up.
Yeah, David, I was trying to make it. That new ruling caught most of us by surprise yesterday, but are we looking to open a can of worms where that is concerned, one, and two, or is it being done behind the scenes to blunt what could be an abuse of the system with the 5 days of the isolation and those kind of things?
Can you expand on what you mean by opening up a can of worms?
You no longer have to take those 5 days, or you go out. So you have to report to work in that in other words, the time that you would have reported when contact is made, or you are said to be in an area where someone has tested positive, and then now you're saying you don't have to go into, you can do differently.
Are you suggesting that it could create a greater spread? Is that what you're
Yes,
saying?
it can. Yes. I'm saying that. And two, or is it to blunt a perceived abuse of the time between your PCA test and the results, and 5 days or 12 days and things like that?
So
You want to take that, Raz?
yeah, for sure. So there was that is a very loaded question. So I'm going to be very careful here and say that we do have reports that some people have tried to abuse the system, but that's a minority of persons. We would like to believe that the average person in Barbados, the average Barbadian, is honest and industrious and not wanting to abuse the system. But let us be real, it can happen, and it has happened in certain circumstances. The main benefit of going to no routine quarantine, and I'm going to stress again, we have not been practicing routine quarantine since December. So this is nothing that is starting from today. This has been going on. We are now discussing it at this particular press conference. The no routine quarantine was decided based on the fact that the numbers were going to be extremely high, and it was going to be very disruptive to businesses, organizations, institutions if every person who came in contact with a COVID positive case was to quarantine. Just a couple of weeks ago, our isolation numbers were up to 12,000. If you take each of those 12,000 and say they probably had contact with a minimum of 4 people, just do the maths. So we're looking at quarantining 50,000 people at any given time, and it could be higher than that. We recognized a long time ago that it was going to be too disruptive, and so we needed, in the development of our strategic plan for the response to Omicron, we took business continuity and contingency planning into consideration, and we said, look, we cannot continue the status quo that was applied in previous waves. We cannot apply it to Omicron because it is going to be very disruptive. So I'm repeating that again. We have to balance good public health practice with what is feasible, and do not employ strategies that will erode the economy and prevent further growth of the economy. So it's a balancing act, and I would argue that the balancing act is working. We are employing a whole host of other strategies, and I would have touched on those before, such as case detection, such as isolation. Then you have all of the non-pharmaceutical interventions, including mask wearing, etc., that we still enforce to reduce the likelihood of spread, and it has been working, and it will continue to work.
Thank you very much, Dr. Anton Best. Also, thanks to Infection Control Specialist, Dr. Forde, as we looked at 3 areas here today: the end of routine quarantine in Barbados, making efforts to stem the deaths of people in the elderly group. And therefore, the key message here is that we need to take early action when the elderly are sick, and new visitation rules at the Harrison Point facility, where people who are already positive and are in isolation, but have close relatives at Harrison Point who are in primary care and are very ill and want to see them, will be facilitated in that particular way. I want to thank you all for participating in today's edition of this particular press briefing with officials of the Ministry of Health A special thanks to those of you in the media and those who sent questions and those working behind the scenes to make it possible. I'm David Ellis. Do have a great day.